So first of all, I would like to thank you very much for the invitation. It's always a pleasure to be here and to be with colleagues involved in breast cancer treatment, and particularly in this period when we need just to show that, let's say, that the life is going on and there is important things that we have to share together. So I will have two presentations, and actually I've split it in two parts. And the first one will be devoted to the molecular disease and the tailoring strategy to tumor biology. I will not go through the local treatment because you have clear and very important experts that will discuss the question of surgery and the question of radiation therapy. So, are we doing some kind of molecular tailoring actually in treating breast cancer? And I will answer very simply yes, and since many years. And at least in one situation was very recently, let's say, remind to all of us, and this is the situation. When you're treating BRCA1 and BRCA2 population, you have to be careful about that. You're taking into account one molecular anomalies. And in fact, when you discuss with the patient, sometimes they know even better than some of the colleagues because they are reading some press, like Time magazine, you see here. And to be honest, maybe that some decision like Angelina's decision make more important, let's say, noise about the importance of BRCA mutation population than even some publication in GCO and New England Journal of Medicine when you discuss with the patients. So this is the level 1 of evidence. When you discuss with the patient, and if they know that there is a clear correlation between some molecular anomalies and what might be the best option regarding the treatment and the prevention of some cancers, and particularly breast cancer, yes, we are tailoring some strategy according to biology and genes since, I will say, many years. But the second point is, what is about the personalized medicine and the molecular disease? And you know, probably this movie, I already use it quite frequently in my presentation. This is the Ingmar Bergman movies, The Seventh Seal. And you see on the left side this is a death. On the right side, this is a crusader, and they're playing a chess party. And what you're doing as oncologists, even if you're a surgeon, radiotherapist, medical oncologist, don't worry. You are doing exactly the same thing. You are playing every day a game against death. And in fact, what we're doing is trying to define the chess party and trying to win the chess party. So what about the tailoring personalized medicine according to some genes? And I will go through what was the perception of the cancer the last 10 years, the breast cancer the last 10 years, just going through one of the guidelines conference you know probably very well, which is the St. Gallen Consensus Conference. So actually, what is the most difficult thing is to define the tumor characteristics. But I will say who cares about that, in fact. If you are treating just small tumors, and if the vast majority of those small tumors will be just cured by local treatment and maybe an endocrine treatment, I don't know if we need to go through very important biology. But in fact, this is not all the patient we have to treat. And we need also to look at several points at the level of genomes, at the level of DNA, at the level probably also of molecular imaging to try to define better what is the biology of the tumor. The evolution of the past 30 or 40 years, when you look at the definition of breast cancer, goes through what was the anatomical and pathological definition, when you see here the breast, then you have the ductal or lobular types, then you have the grades. But in parallel, what happens regarding the molecular definition of breast cancer, it goes through several steps. The first steps was, reminded by Professor Kutten, this was, even if it was, let's say, approached by a very pragmatic way by George Beatson at the end of the 19th centuries, the first publication clearly showing that there is a correlation between the estrogen receptors and the issue of those patients was in the 1970s. And the beginning of the history of adjuvant and metastatic endocrine treatment was exactly on the same period. So about 40 years, 50 years from here. So you see that in the history of breast cancer, the molecular or the very simple approaches regarding the targeting treatment is very, very small according to the history that we know about cancers, and particularly breast cancers. So 1970s, the estrogen receptor, and this was William Maguire publication. When you look at the 1990s, about 20 years after, the HER2 positivity and the correlation between endocrine resistance and HER2 positivity. And this is also an issue from the Maguire laboratory. That doesn't mean that the other one do not work. That means just that at that time, what was very important, and I will encourage you, is to have clinical database and tumor database. Because if you want to go through genome aspects, and if you want to go through these kind of approaches, trying to better define the molecular biology of the tumors, if you don't have tumor samples, and if you don't have clinical data, it will be always difficult to go through, let's say, what is the revolution of the biology. And then we have, from several parts of Europe and all over the world and in the US, the definition of the molecular portraits of human breast tumors, and the new publication in 2010 concerning the new molecular definitions. If you go back to 2005, this was the statement of the St. Gallen Consensus Conference. And when you see it's less than 10 years before, what was the definition of how we have to treat patients? It was according to the risk and nothing more. And the only point was that HER2 is potentially a prognostic factor, but in 2005, we are here in the adjuvant setting, no one was deciding the type of the treatment according to any molecular aspects. The only fact was endocrine responsive or not responsive, but you see that the approach was very simple. Then in 2007, we moved with the integration of clearly the HER2 negative and HER2 positive disease. 2 years after, we split the strategy not according to the risk, but according to the predictiveness of a response. You have here the endocrine responsiveness, and on the other side, the HER2 potential responsiveness, HER2 negative and HER2 positive. And the combination of these two predictive factors clearly define the way we will treat the patient. For those who do not have any, let's say, predictive factor of targeting any molecular aspect of the disease, the only treatment that we can propose is, regarding the systemic treatment, is the chemotherapy. Then we move in the same period with what was mentioned also by Professor Kutten, what was the definition of some molecular prognostic tools. And this was a publication from the GNCI 2 or 3 years before, just looking at several signatures. You have the 70 gene signatures, the mammoprint, you have the 21 gene recurrence score, the Oncotype DX, and another one. We have actually some new signature looking at the prognosis and the prediction of some treatments. But in any case, at that time, that makes sense, is trying to better define the prognosis of the disease according to some molecular tools. And in this publication, and I will just focus on 2 or 3 points, when you see the level of evidence, the 21 gene score was level 1, the other one, 70 gene signature, was level 2. It was stated by the people who wrote clearly the paper. So you have to always to be careful, because this was one of the mention on the GNCI publication. But when you look at another way to predict this, is what was the integration of these molecular tools to the everyday practice. And I will go through the impact, you know, probably this meeting. This is a meeting devoted to the molecular biology and the biology of breast tumor every 2 years, and this year it will be also in Brussels. And they have just looked exactly the same thing, the utility of the prognostic genomic test in breast cancer. And they have looked at several tests. You see exactly the same, the Oncotype DX and the mammoprint, but also some other one. And they take into account some different models, looking at, in their publications, what we have concerning the interaction between the tumor size, the nodal status, the estrogen receptor, progesterone receptor positivity, the HER2 positivity, and several parameters, and try to look at the multivariable models if we have some clear definition of the impact of these different signatures. But more interestingly, they will judge the level of evidence concerning the importance of this signature. And they take the EGAP criteria. Those criteria are used in general medicine and cancer. It's the evaluation of the genomic application in practice and prevention. And those criteria split into 3 different parts, the validity of the test. The first one is the analytical validity. And the answer is, for all those tests, yes, they are valid regarding the analytical validity. They have done simple analysis, intra-lab reproducibility, they have clearly defined the characteristic of specimens, and they have reported also some difficulties regarding the test failure. If you look at the clinical validity, there is a second step. What does it mean? Do we have some data from clinical perspectives? And this means that in the majority of the case, those data provide sensitivity, specificity, and some hazard ratio sample size for calculating the possible impact and the possible clinical validity of the test. But the most important thing is it with a clear level of evidence for clinical utility? That means that if in everyday practice you might use this kind of tests. And this means that we have randomized trial and meta-analysis, prospective and retrospective data collection, but most importantly, independence of the test in multivariate analysis, showing that we have added value regarding this genomic test according to the previous test we use to define the prediction and the prognosis. And according to the EGAP criteria, I will go through, if you look the different, let's say, scientific society stating on the importance of these genomic tools, ASCO said, okay, you can use oncotype reads and potentially even mama print, why not? If you look at the French National Institute, the answer was no. If you look at the EGAP criteria, it's probably not for clinical utility. If you look at St. Gallen, the answer is yes for oncotype. And if you look at the impact working group, the answer is probably not for clinical utility for all of these tests. So we move from what we know, the TNM classification, the histological types, the histological grade, the integration of the predictive and prognostic estrogen receptor and HER2 factors, and then we have some discrepancy. We don't know actually if we can move on and using clearly in everyday practice these molecular approaches. But in any case, in 2009, St. Gallen stated that actually, if you look at the different way we can split the prognosis of the breast cancers in the adjuvant setting, we will use different tools, and the conclusion at that point was in fact that we might move to the definition of what is called the luminal A, the luminal B, the HER2 positive, and the basal-like tumors. But I would like to go back to the first paper describing different types. This was published in 2000, and at the end of the paper, probably not the end, sorry yet, one of the parts of the paper, clearly Charles Peru stated that basal-like cancer are associated with bad prognosis and are frequently estrogen receptor and HER2 negative. And from this statement, this was the first confusion. That means that the triple negative disease is a basal-like. No. That means that more frequently in triple negative disease, you have basal-like tumors. Let's say 7, 8, I don't know, 9 years after, in the New England Journal of Medicine, which is the gold standard of publication actually, not only in oncology, but in general, you have this kind of table. We move from what was the molecular definition to clearly, if you are HER2 negative, estrogen receptor negative, you're basal-like. If you are HER2 positive, you're HER2. And if you are HER2 negative, estrogen receptor positive, so looking to the differentiation of the Ki-67, you might split the population between what we call the luminal A and the luminal B. There is no demonstration of this correlation. There is a tendency, but no demonstration. And it's why we have to be very careful between what we think is the molecular basis of the treatment and the clinical basis of the treatment. And in 2011, when you look at the statement of St. Gallen, clearly There is no more definition of what is a criteria of aggressiveness of the disease. We move to luminal A, luminal B definition, HER2 overexpression, and basal-like, you see, without any clear clinical correlation between what we think is the molecular definition and the clinical definition according to the immunohistochemistry. And back to 2011 statement, this is clear, in luminal A, endocrine treatment. In luminal B, HER2 negative, endocrine and dependent of cytotoxic therapy. In HER2 positive, we have to have the antidote treatment. And in triple negative, because we don't have nothing to propose, then we can use cytotoxic. We just change the way we define the tumors. But more difficult is that we have defined it without any clear correlation between biology and clinical statement. Back to Charles Perroux' second publication in 2010, the title of the publication is, in my point of view, very important. It's Deconstructing the Molecular Portrait of Breast Cancers. Looking at the first definition and trying to understand better what is the molecular definition of breast cancer. And he just split what we call the basal-like between the Claudine low and basal-like, the HER2 enriched, luminal B, luminal A, and there is this normal group. And you see that it clearly gives some information concerning the data set regarding the prevalence of this kind of disease, the estrogen receptor, progesterone receptor, the HER2 positivity, the triple negative positivity, the grade, the tumor size, and for those patients who are treated in the neoadjuvant setting, the pathological complete response. And then the definition that's this one. If we imagine that the basal-like and the Claudine low are triple negative, let's move to the table and look at this population. Those are the triple negative, okay? HER2 negative, progesterone receptor negative, and estrogen receptor negative. In the triple negative disease, you have 22% of HER2 enriched, you have 10% of luminal B, potentially 5% of luminal A, and even, you can see here, about 80% of the population is basal-like or Claudine low. There is no strict correlation. And 20% difference, that makes sense if you want to just go through clinical trials trying to target this kind of population. If you look at the HER2 positive population, we have about 20% of HER2 enriched in Claudine low and 10% in basal-like, but we have also in luminal B about 20% of HER2 enriched, and even a small number, about 8% in luminal A. Do we have to take into account this definition or this definition? And you will see that it makes sense sometimes. For the luminal B and the luminal A, we have exactly the same thing. The only way we can have a, let's say, simplistic approach is that, in fact, it seems that they are more chemosensitive if they are here, and they are more endocrine sensitive if they are here, and nothing more. The only thing, according to the molecular definition, is this one. In 2013, the last St. Gallen consensus statement, we do not move too much. The lot of the discussion looks at the cutoff of Ki-67, trying to define what is a luminal A and what is a luminal B. So you can imagine that you have a lot of experts and just discussing about if you have to put the cutoff at 10%, 15%, 20%, and 25%. Does it make sense? Yes. And this is a slide that my friend Giuseppe Viale gives to me. It's actually, I think, under publication, but I'm not sure that it's even published. If you look at the Milan database, looking at the definition of luminal A and luminal B subset, and if you assume that you will give chemotherapy to luminal B and not chemotherapy to luminal A because they're endocrine sensitive and not chemosensitive, if you put the cutoff of Ki-67 at 40% and 20%, this is the way you will have the repartition between the luminal A and the luminal B, and that makes a difference. Just because some experts have decided that they will put the cutoff at 50% or 20%, you might undertreat or overtreat 20% of this population. This is molecular biology statement? No. This is just a consensus statement. And we have to be very careful about that. So, as it was mentioned by Abraham, here are actually the personalized medicine that we use to treat the patient. And we have the clear prognostic and predictive factors. It's quite difficult to define well the proliferation. and the molecular signature that might be used in the different consensus statements. And to be honest, I'm not using this in everyday practice clearly. The second point is the treatments. And if we have to go for the treatment, I will go back through the way we treat the patient with the decisional parameters. And since, let's say, a little bit less than 10 years, we are just looking to the tumor biology-driven HER2 positivity, estrogen receptor positivity, and the way we will treat the patient. The thing that we had in metastatic disease is sometimes some bone localization, the brain localization, and potentially we want to define what is the angiogenic switch, but we are far from the way we will define it actually in the metastatic disease, in breast cancer. So what do we have to trying to use the molecular approaches to better define the systemic treatment? The first question was HER2 amplification and topoisomerase II in using anthracycline. And we have several publications. One of the most important was the publication from Angelo Guillet when he was in Belgium, in Brussels, in the Martin Picard team, and just showing here that there is a correlation between the HER2 amplification and the topoisomerase II alpha gene aberration, and it's a predictive marker of patients that might benefit from anthracycline in this population. We have also the Alessandro Gennari meta-analysis showing that clearly the HER2 status and the efficacy of adjuvant anthracycline are correlated. And that makes sense because one of the points is clearly that anthracycline makes a difference. It was shown in the meta-analysis, but maybe the most important added value of anthracycline was initially in the HER2 positive population. And the last point is, do we have any correlation between the alteration of the topoisomerase II alpha gene and the responsiveness to anthracycline-based chemotherapy? And there is some publication showing this, but we don't have level 1 of evidence. That means that actually the real place of the anthracycline and the way we have to use it is clearly not very well defined. We're using it less because we're using anthracycline and taxanes, but if you remind the last publication of the meta-analysis, there is some discrepancies between the real impact of the chemotherapy regimens according to the dose density, and we have to be very careful about that. Do we have also other point concerning the impact of the taxanes? And it always goes on the same direction. The HER2 positive population seems to benefit more from treatments and more for taxanes. And this was also what they find in the adjuvant trials exploring the paclitaxel in the node-positive breast cancers. And in this population also, in HER2 positive, they might benefit better from the paclitaxel than according to the HER2 negative population. And last thing, according to HER2, I will go through the neoadjuvant setting in a few minutes. Just to come back to what we call resistance or adaptability. Abraham showed you the metro card of Kiev, and this is just, let's say, when you are looking at the surface of the cell and the framework between the different HER2 and HER1, HER3 and HER4 possibility to combine for the heterodimers, the way you will have transduction of the signal and the way the cell might respond. And from this hypothesis and from some clinical statement of patient progressive after anti-HER2 treatment, we have tried to define the resistance to an anti-HER2 treatment. We learn a lot from neoadjuvant setting, and even if I will go through in a few minutes, just remind you that in the neoadjuvant setting, what is the most interesting for us is the correlation between the pathological complete response and the DFS and potentially the overall survival. We have the possibility to address the question of the best strategy regarding the systemic treatment when you look in neoadjuvant setting in some population, in luminal B HER2 negative, in luminal B in non-luminal B HER2 positive, and in triple negative particularly. One of the last trials exploring the neoadjuvant approach in HER2 positive disease was the NEOSPHERE trial. And in the NEOSPHERE trial, you see,
We have looked at the combination of trastuzumab plus docetaxel, the doublets of antibodies, the doublets of antibodies plus docetaxel, and pertuzumab plus docetaxel.
I will not go through the results, but just to show you,
this is the level of pathological complete response you might achieve according to the estrogen receptor status, positive in yellow and negative in blue.
But most interestingly, if you look at what is defined as a resistance,
there is here the percentage of patients who do not respond or progress
during the neoadjuvant setting.
You see, we have 0, 1%, 2%, and 7% for those patients who have received the 2 antibodies without any chemotherapy.
That means that if resistance is defined by the way we define the resistance in everyday practice, progression, primary resistance, progression during treatment, it's very low number of patients who have this kind of resistance. So if we don't think about the way we will explore these molecular abnormalities and the way we will define it, it will be very difficult to understand the mechanism. The way I would like to go back to the definition of the molecular biology is to go through a neoadjuvant setting. And this was presented last year at the ASCO meeting by the US team. And you see that in the neoadjuvant setting, they just explore the way they will treat the patient with weekly paclitaxel and doublets of lapatinib plus trastuzumab, weekly paclitaxel plus trastuzumab, or weekly paclitaxel plus lapatinib, and then surgery. And the primary endpoint was the response and the pathological complete response, assuming that the doublet will do better than just one drug. And the answer was, well, yes.
If you look independently of the estrogen receptor positive or negative, when you use 2 antibodies, it's better, 2 anti-HER2 treatments, it's better
than when you use just one. Okay, we know this from several trials. But what makes the difference in this trial? They have looked at the molecular biology, and they have just addressed the question. I don't care about the HER2 definition by immunohistochemistry. I take all the patient treated, and I will look at the definition of the disease according to Charles Perroux definition. And what was the results?
The first one is that, in fact, you have HER2 positive disease according to the definition in 1/3 just of the patient. You have 20% of luminal B, 1/3 of luminal A, and you have basal light in 7%
and normal light in 6% of the population. That means that the definition between our everyday practice immunohistochemistry and FISH and the molecular definition is not very clear. The second point is that it makes sense when you look at the estrogen receptor positive subtype or estrogen receptor negative. And the answer is yes. In the estrogen receptor negative, half of the population is clearly HER2 positive according to the molecular definition. But in the estrogen receptor positive, we have just 20%. And does it make sense according to the impact of the treatment? And the answer is yes. Because when you look at the molecular definition, if you are HER2 according to the molecular definition, you have about 90% probability to respond. If you are luminal B, luminal A, you have about 40, 33%, and 50% for the basal light. That means clearly that there is no strong correlation between the definition of the subtypes according to the molecular definition and our everyday practice clinic definition. That doesn't mean that we have to change practice and use a molecular biology, but means that we have to be very careful about the way we'll define it. So the conclusion too is that if you use personalized medicine in breast cancer according to the treatment, among all the chemotherapy regimen choice, chemosensitivity probably depends on the molecular subtypes. HER2 positivity and triple negative breast cancer are generally more chemosensitive, and TOPO2 might be an interesting target for anthracycline, and it's frequently associated with HER2 positive status. Regarding the HER2 positive disease, it's really difficult to define the resistance. The double HER2 blockade is more effective in general. We know that the PA3 kinase actinium-2, and I will not go through, is a pathway activated, but we don't have clear correlation between this activation and the resistance to a particular molecular target treatments. And it will be probably possible in the future to identify the HER2 positive subpopulation who do not need chemotherapy, because this is one of the most important issues. As it was mentioned by Abraham, we have
treated patients who have saved a lot of life with definition of HER2-positive population. Now we might go back, like in lymphoma, and clearly define those who just need an anti-HER2 treatment without any chemotherapy. The third part concerning the molecular targeting is about patient, disease, and time. And I will just go through what was our simplistic definition of the cancer, the anti-cancer drugs, and I've just put here the metabolism. And in fact that we are treating is metastatic disease. Even if in the adjuvant setting, we are defining the micromets disease. And you know that actually we have Darwinian selection of the metastatic cancer. And when you are using drugs, you might be careful because you don't know what you are doing, looking at the metabolism of the drug. And the second thing is that maybe some of the drug will not go to the targets. And last, even if they go to the target, they might be effective of one of the target, but not to the other one. What does it mean? It means that one of the most important questions actually we address in everyday practice is, if I have a metastatic disease, do I have to rebiopsy the tumor? And does it change something? Because we can do a lot of biopsy, but does it change something in everyday practice? Does it mean that if I have a new statement concerning the biology, concerning the molecular approach, it changes the way I will treat the patient? And their answer is, we begin to have some answers. The first answer was given by the Johannesburg group. They have looked in a data sample size of more than 1,000 patients who have been rebiopsied and assessment of the estrogen receptor, progesterone receptor, and HER2 status. And the first information was that it's terrible. It's changing always. You could not assume that if you have one estrogen receptor positive mets at one time, you will have, if you rebiopsy 3 years after another met, it will be estrogen receptor positive again. So it's an adaptability. It's not a resistance, it's an adaptability of the tumor to the microenvironment. And the second point was, if we treat the patient according to the primary status or the rebiopsy, if it doesn't change, this is the best prognosis. But if it changes, then you have to be careful that maybe you have to take into account the fact that if it was estrogen receptor positive and became negative, you might change your strategy. This is the only trial showing that it might be interesting to rebiopsy and to integrate the information to change the way you will treat the patient, impacting the prognosis in the metastatic disease. In the ESO International Consensus Guidelines for the advanced breast cancer, we have stated that yes, we need to biopsy, but when you ask the expert, and if you biopsy and if the patient was HER2 positive, and you have the biopsy which is HER2 negative, you will treat the patient without anti-HER2 treatment? The answer was no, we will continue to use anti-HER2 treatment. So why you are biopsying the patient? We are just trying to find positivity and not negativity, and that makes a difference. And the third point, do we need to biopsy every time? We have actually a program in my hospital looking at the FDG. This is a patient of mine with metastatic breast cancer, positive breast cancer, estrogen receptor positive and HER2 positive. And she was treated in a program with 18 FES, with fluoroestradiol. That, assuming that if you have fluoroestradiol captured by the tumor, that means that you are estrogen receptor positive on the tumor. The biopsy was positive here on the lung. But when you look at the positivity from the FAS, it's totally negative. And the patient do not respond to endocrine treatment. That means that even if we have the target, even if we have the signals, we could not assume that we clearly define the resistance of the tumor, even the accessibility of the potential drug to the tumor site. Does it make sense to have a systematic molecular approach in metastatic disease? And the answer is potentially yes. This is a molecular portrait of human breast tumors according to primary tumors. And you see that even in the very, very high-level scientific publication, this is in Nature, clearly they define according to the luminal A, luminal B, so different subtypes, but they have looked at the somatic alteration, some amplifications, And here you have some criteria according to Siemens chemistry. And this is a molecular portrait of breast cancer at the time of the initial diagnosis without any metastatic disease. And they defined 4 main breast cancer classes. Some somatic mutation, which are quite frequent, P53, PI3 kinase, and GATA3, and over 1 defined like the Charles Perrow duplication, defining the luminal A, the luminal B, the HER2, and the basal-like. We have one trial in France, was finished 2 years before, the Saphir-01 trial, addressing the question of, is it interesting to have the molecular portrait of the metastatic disease, and is it feasible? But the fact is not only is it feasible, does it change something in everyday practice? And the patients were included in this trial, about 500 patients. They have some biopsies, then they have some tumor sequencing, whole genome profiling. And when we try to identify here the possible targetable molecular anomalies. And these are the results. 423 patients included, 408 with biopsy metastases, 300 with whole genomic profiling, about 200 with some identified genomic alteration, about 60 of them were treated in targeted therapies, and at least we have 30% of clinical benefit rate. So yes, it's feasible, but does it change something in everyday practice? I will be very provocative. Nowadays, no. But sometimes it changes. The first thing is, when you look at the very first publication from my friends, they identified, as it was mentioned previously, the P53, the PI3 kinase, and some different genomic alteration that might be frequent and interesting in breast cancer. But in the last presentation in San Antonio, they just go back and look at several points that was not looked on the primary tumor initially in the first publications. Those one. Estrogen receptor mutations, about 10%. And you see here that there is a huge difference between the primary tumor expectation regarding this kind of abnormalities and what is the place in metastatic disease. That means that when you compare the profile, the genomic profile of the metastasis and the primary tumor, that might give you some information of what are the alterations that make sense in the metastatic disease. So do genomic tools impact daily practice in breast cancer treatment? Yes, at least. It helps us to take better decisions and better guide clinical research. But I will just mention Aldous Huxley, there is only one corner of the universe you can be certain of improving, and that's your own self. That means you have to be very careful the way you read the papers. You have to be very careful the way you integrate the results. And don't forget that at the end of the day, if 80% of the patients are cured by local treatment, surgery, radiation therapy, and very simple approaches, you don't have to care about biology. Just care about the 20% you have to define with more aggressive disease. Thank you.
Спасибо, профессор Гligorov. И вторая часть, вторая лекция.
I'm moving to the neoadjuvant.
Yeah.
Okay. Sorry, you will have to hear me again. Thank you. I will have a more pragmatic approach for the neoadjuvant setting. And just to remind you that we have three questions I want to answer. What are the goals? What is the population we have to target for the neoadjuvant setting? And what are the tools? The goals are very simple. We have three clear goals in neoadjuvant approach. The first one is oncologic. It's impossible to have a primary optimal local treatment. This is clearly an indication for the T4D, for the N2 tumors. When you discuss with the colleagues, with the surgeon, they will be more comfortable, even if they do mastectomy, to have first a disease control, a shrinkage of the tumor, and then on the second step, having the local treatment. The second one is the aesthetic. It's impossible to have a conservative oncologic treatment. You will better improve the cosmetic results using the neoadjuvant approach. And the last one is more and more frequent. Is a scientific point of view, the way you will use a neoadjuvant setting to improve the quality of the cares, to improve the quality of patient treatments, not only in neoadjuvant, but also in adjuvant, and maybe also in metastatic disease. So from the oncologic point of view, it's saving lives. I don't care about the cosmetics. I know that if I do not apply neoadjuvant treatment, I will decrease the probability of curing the patient. From the aesthetic point of view, it's saving breasts. And from the scientific point of view, it's optimizing the treatments we have. So, on the left side, you know Bernard Fischer, which was the chair of the NSABP, and I would say the first clever surgeon saying that, you know, breast cancer is a systemic disease. Even if I agree with Abraham, it's not only a systemic disease, because with mammography screening, actually, we see that the majority of those patients do not have any systemic disease. They will be just cured by local treatment. In fact, the risk of mortality is due to the capability to have a systemic disease. And that makes sense to clearly define this population. And he was the first trying to approach the neoadjuvant approach in randomized trial, but we have, on the same period, in Pitié-Salpêtrière in France, which is one of the hospitals of the university when I'm working, the neoadjuvant approach with Claude Jacquia, chemotherapy or combination chemotherapy with radiation therapy, trying to better control, locally control the disease. From the NSABP, and this was the B18 and the B27, the B18 with a publication more than 10 years of follow-up, when you see at the impact of the pathological complete response, that means you don't have any tumor on the breast and the axilla, even if here it was just breast. On B27 it was breast and axilla. You see that there is a clear correlation between achieving PCR and the overall survival benefit. In the B18 and also in the B27, the difference is this is AC regimen and this is AC followed by docetaxel. So the conclusion from the NSABP trial initially was it's possible and it's feasible to do neoadjuvant approach. It doesn't change nothing. But in fact, the more interesting from a scientific point of view information was if you achieve pathological complete response, you might define the population that clearly benefit potentially from the systemic treatment. So, because we are I'm treating as medical oncologist everyday patient in the adjuvant setting, and to be honest, when you think about that, the only patient I know the results are the negative results. Let me explain this. If you treat a patient with chemotherapy in the adjuvant setting and there is a relapse, you will assume that the treatment that you have given was not effective. But if there is no relapse, you could not assume that the treatment that you have given was effective or not. So I just have a negative interpretation of the way I treat the patient, because I just can capture the negative results, saying to me, what you have done is not the good thing. I know that I've cured probably some patient, but it's impossible clearly to define this population in the adjuvant setting. So the neoadjuvant chemotherapy is as important for the oncologist as a white stick for a blind person, because I know exactly for whom I could have a clear benefit. Back to the molecular subtype. We know that this was a very small publication by the MD Anderson group. We know that according to the subtype, the HER2 positive and the basal-like tumors are sensitive to neoadjuvant approaches regarding the PCR objectives. This is the conclusion from the German group, the Gunther von Minkwitz group, looking at several trials exploring in the neoadjuvant setting different combinations. And this was published in GCO 2 years before, and clearly he defined that using the neoadjuvant approach and defining the luminal A, luminal B according to the immunohistochemistry, with this discussion we have a few minutes before, according to the cutoff of Ki-67, it was 20% here. You see that in some subgroups, achieving PCR do not make any sense. In luminal A, no. In luminal B, HER2 positive, no. What does it mean? It means that in this population, when you can, after neoadjuvant treatment, probably have a very important targeting treatment, not very aggressive disease, endocrine treatment, aggressive disease but endocrine treatment and also anti-HER2 treatment, achieving PCR is not strongly correlated with DFS and overall survival. But on the other one, luminal B, aggressive endocrine sensitive, but you don't have the possibility to have clear effect of endocrine treatment after, and you don't have anti-HER2 treatment, it makes sense. The same thing for the HER2 positive non-luminal, so estrogen receptor negative, and the same thing for the triple negative. There is a correlation between PCR and DFS. In New England Journal of Medicine in 2012, the FDA regulatory authorities published a very interesting paper, Pathological Complete Response and Accelerated Drug Approval in Early Breast Cancer. That means that it's possible to develop the drugs in neoadjuvant settings. And this was published in February this year in The Lancet, the meta-analysis of the different trials trying to understand the correlation between the neoadjuvant treatments, the achieving of PCR, and the impact of DFS and overall survival. So about 12 trials, I think a little bit less than 2,000 patients were excluded, but 1,200 were included for the analysis. And here are the results. If you look at the association between PCR and event-free survival and overall survival, achieving PCR, in red here, is clearly, once again, associated with an event-free survival and with an overall survival impact. The second point is the way we define it. And it's exactly the same thing that in biology and in molecular biology. If you do not define clearly, does it mean pathological complete response in the breast and in the axilla? That doesn't mean if you include in situ positivity or not, you will have small changes regarding the event-free survival impact and the overall survival impact. This is the association between the free definition of PCR and event-free survival or overall survival. So we have, once again, before going through, define the way you will look at the PCR. And what are the parameters that are influencing the PCR? You see those parameters here. It's clearly the HER2 positivity and the triple negative disease in this part. And the other one regarding influencing overall survival benefit in case of PCR, once again, HER2 positivity and triple negative. So looking at the meta-analysis, we have exactly the same information that we have from several trials. The more chemosensitive are probably those who benefit more from the neoadjuvant treatments. And if you look at the different subtypes, there is a correlation between PCR and overall survival. You see here in HER2 negative, hormone receptor positive. You see here in HER2 positive. You see here in triple negative. But more difficult to achieve in the luminal A or in the HER2 positive luminal B. I mean to achieve this correlation between PCR and overall survival subtypes. The second point is what are the population? So what we know is that we can treat the patient with chemotherapy. We know that it's validated for inflammatory breast cancer, for locally advanced. It's not validated to use neoadjuvant for the bad prognosis breast cancer. So saying that it's a bad prognosis, so we'll use neoadjuvant makes sense, but it's not validated. We have to be careful. And there is no superiority defined versus the oncoplastic surgery if the endpoint is just cosmetic. So once again, we have to be very careful about these approaches. The third point is the tools we will use to achieve the response in neoadjuvant setting. I will go through the three tools, the endocrine treatments, the anti-HER2 treatments, and the chemotherapy treatments. Regarding the endocrine treatments, the population is clearly defined. It's the estrogen receptor positive, So luminal A, oops, here it is. So luminal A and luminal B. The question is, what about the menopause woman? Because it makes sense. We don't have very clear demonstration of the endocrine approach in neoadjuvant setting for the non-menopause woman. The objective, is it aesthetical or scientific? And the modalities, aromatase inhibitors plus eventually other targeted treatments. And we have very, very small amount of data regarding the randomization between just chemotherapy and endocrine treatment. This was published in Annals of Oncology from our Spanish colleague, I think in 2011 or something like that. It's a small trial, you see here, with two arms in patient comparing the epirubicin cyclophosphamide versus just the exemestane. Is it more clear to have an impact in estrogen receptor positive population in the neoadjuvant setting with endocrine treatment, with chemotherapy, or potentially it's the same thing? And if you look at the results, you see here that you have the menopausal status of the patient. I think here it's probably the age, sorry, the estrogen receptor value, and you have about 100 patients randomized in these two arms. And if you look at the overall response rate, it's better in the general population with chemotherapy comparing to endocrine treatment. But if you look according to the Ki-67 cutoff, you see that it makes sense. If they are more proliferating, probably they benefit more from chemotherapy. If they are less proliferating, they benefit equally from the endocrine treatment. So from the endocrine treatment position, yes, it might make sense, but we have to be careful to select what is clearly a luminal A or an endocrine sensitive population, even if we could not define it very clearly. What about the anti-HER2 treatment? The population is HER2 positive. We have three types of objectives: aesthetical, oncological, and scientific. And the modality might be the chemotherapy anti-HER2 or the combination of different anti-HER2 treatments. The first trial defining clearly the impact in neoadjuvant setting of an anti-HER2 approach was the NOAA trial with trastuzumab in combination with anthracycline and paclitaxel in HER2 positive and in HER2 negative disease. And here, when you look at the pathological complete response, clearly in the HER2 positive disease, it makes sense that you will use, regarding the overall response, the addition of an anti-HER2 treatment. When you look at the second generation of treatment in the neoadjuvant setting addressing the question of the optimal way to use anti-HER2 treatment in these situations, this is the Neosphere. I already mentioned it in my first presentation. Combination of trastuzumab plus docetaxel, pertuzumab plus docetaxel, the two antibodies, and two antibodies plus the chemotherapy. And if you look at the pathological complete response, the better arm is this one. About half of the population will have a pathological complete response using the two antibodies with the chemotherapy regimen. This is what you have. But we have several information in this slide. The first one is that in general, you will achieve better rate of pathological complete response in estrogen receptor, progesterone receptor negative population. So if the goal is PCR, better use this approach in estrogen receptor, progesterone receptor negative population. The second thing, it's better to use the two antibodies with chemotherapy. But the third thing, there is one subset of patients here who do not have any chemotherapy, just pertuzumab and trastuzumab without chemotherapy. And if you look, there is 30% of those patients who achieve pathological complete response. That means that maybe we can identify here a population who do not need to have any chemotherapy using the neoadjuvant approach in estrogen receptor, progesterone receptor negative population. We have other trial demonstrating in the neoadjuvant that the combination of trastuzumab plus lapatinib will give better result than lapatinib alone or trastuzumab alone. This is the same thing regarding the pathological complete response in the breast or in the breast and the axilla. And comparison between two ways to block HER2, lapatinib versus trastuzumab in the neoadjuvant trial, the GEPA-Quinto, demonstrating that when you use trastuzumab, you achieve better PCR than when you use clearly lapatinib. And the last thing is the way you will develop the drugs. You know that you will have potentially a new formulation of trastuzumab, the subcut. Just to mention that this was developed using the neoadjuvant concept, demonstrating that a novel way to deliver the drug by subcut administration will give the same result regarding the PCR. And this is probably the way the biosimilars will be developed in the neoadjuvant setting. So the last point is regarding the chemotherapy. I have 5 minutes to finish? Yes. Okay. So the ABCTCG group, this was not initially published, but it was shown on the Oxford overview in 2006 in the neoadjuvant setting, showing that 80% of the patients who have received neoadjuvant approach have less extensive surgery. And this was the statement. The problem was, do we have differences regarding the local recurrences? And the answer is yes, a little bit more, clearly in the neoadjuvant approach. And we have to clearly define the way we will treat the patient before the neoadjuvant setting if the objective is a cosmetic one. If you look at any recurrences and the breast cancer mortality, there is no difference between the neoadjuvant chemotherapy or the standard chemotherapy after the surgery. This is an important point. And what do we have concerning the standards? The first one was comparison between neoadjuvant and adjuvant with anthracycline, free trial, the UK trial, the URTC, and the NSWP, showing that there is no difference between 3 months of pre-op or post-op, including anthracycline. The second one was also the Italian trial and the NSWP, showing that 6 months pre-op versus 6 months post-op doesn't make any difference when you use anthracycline and taxanes, so it's the same thing. The fact is that the percentage of conversion from mastectomy to lumpectomy, makes a difference. And you have, as always in some Italian trials, you have wonderful results. The issue is in fact that when you look after at the results in general population, it's a little bit more difficult to have the same results. But in any case, 80 followed by CMF, you have 100% of conversion from mastectomy to lumpectomy. This was not a double-blinded trial, because it's impossible to have double-blinded with this objective. But the most important thing is the downstaging. When you look at the neoadjuvant versus adjuvant, and the downstaging regarding clearly also the lymph node involvement. So the new question was, at that time, might we use the neoadjuvant strategy, the neoadjuvant approach, to increase and improve our strategy to treat the patient? As medical oncologists, we have always think that if we have an effective A treatment and an effective B treatment, using A plus B might be more interesting than A or B. But this is the point when you look at this small trial, the Aberdeen one, looking at anthracycline approach, then comparing in case of no clinical response or response, the switch to taxanes versus the switch to taxanes or the maintenance to the same chemotherapy. And what was very, very important for this small trial, and looking at the neoadjuvant approach, that in fact is the population who benefit more from changing strategy are those who are responding to the first treatment. That means the selection of the population is, in this point, first step. I could select those who do not respond, and actually adding a new drug will not change regarding the chemotherapy, the results regarding the PCR. That made me interesting to develop new approaches regarding some molecular tools. But the other thing is that if it works, it's better to change than to continue with the same drug. Because that means that probably you will increase the PCR and the response with the new approach, switching from anthracycline to taxanes. This was exactly what was demonstrated also in the Gepard trio trial. And this was my last slide, saying that probably if we think on the neoadjuvant approach, it depends on the epidemiology of the population you have to treat. In some countries, when you don't have mammography screening and when you have, let's say, big tumors, the cosmetical approach and the oncologic approach regarding the inflammatory breast cancer and the locally advanced, clearly the neoadjuvant setting is important for these issues. Actually, in countries where we have some small tumors detected, maybe we are switching from the first approach of the neoadjuvant to the second one, scientific point of view, trying to develop more carefully the drugs and the way we will improve the selection of the population according to the resistance of the system of treatment. Thank you.
Я хочу поблагодарить профессора Гligorova за исключительно глубокие и обширные обзоры по двум представленным темам. Пожалуйста, если есть вопросы, профессор Gligorov. Доктор Жигулин из Лесот, пожалуйста.
Раз-два. Спасибо за прекрасный доклад. Очень интересно. Если позволите, два вопроса. Один глупый. Будьте добры, вот ваше отношение к различным медицинским калькуляторам типа адъювант онлайн или аналогичным в ключе вот, так сказать, такой обширной разницы, такого количества нюансов, исходя из биологических характеристик опухоли. То есть насколько в обычной практике клинической можно использовать вот такие вот, в общем-то, удобные и понятные для пациентов приемы, как медицинские калькуляторы.
So, I was always worried by what you say, the silly question, which are in general not so silly and very important questions. Let me give you the examples that we use actually in my institution. The reimbursement of the genomic tools like MammaPrint or OpenTypeX are not actually done in France, so it's not reimbursed. What we know from Adjuvant Online and the publication, it's when you try to compare series in general, it works pretty well. That means if you want to have a global photography of the population using the Adjuvant Online tools, it's not so bad. From an individual point of view, it's more complicated. So I will say that it's better to use Adjuvant Online than nothing. This is the first point. But you have to be clear and assume that first, the clinical data you have are the most important. Two, the quality of the pathological data are more important than the Adjuvant Online tools. So if you have good pathologists giving you some clear information concerning the level of expression of estrogen receptor, the HER2 positivity, the level of differentiation, the proliferation index according to several tools, that makes more sense initially to take decision than Adjuvant Online. Then you might use Adjuvant Online in some situation, I would say. It's what I'm doing in everyday practice with some patient when I'm not comfortable to the decision of chemotherapy, which is clearly very endocrine sensitive, but I think very endocrine sensitive population with no node positivity or one or two positive lymph nodes, or small tumors with some aggressive biological parameters. But to be honest, the small tumors are not integrated in the Adjuvant Online because this is a nomogram integrating results from several prospective randomized trials, and in the vast majority of the case, those small tumors were not clearly included in these trials. So it's difficult to answer the question from the small tumors with aggressive biological parameters in Adjuvant Online. It usually underestimates the indication of the chemotherapy, and I use it more comfortably for the endocrine responsive population when I have discussion about the chemotherapy. But I don't know if the colleagues have other approaches.
Спасибо. И второй вопрос по поводу неоадъювантной химиотерапии. Скажите, пожалуйста, является ли фактором влияния, да, то есть вот одним из факторов, который влияет на выбор лечение, его эффективность в именно неоадъювантной химиотерапии, это возраст пациента.
We don't have clear data concerning that. What we know is that in general, the younger population have more aggressive disease according to biology. The second point is that probably doing chemotherapy, doing endocrine treatment, but also doing chemotherapy, we have published that a few years before, according to the menopausal status, makes differences. Because the metabolism of some drugs are probably different in the menopause versus non-menopause patients. But the third point, what might be also important, I have not discussed this, is the immunology. The immunology of the elderly is not the same as the immunology of the young population. And what we know actually is that the lymphocytes on the tumor are associated, I mean the presence of lymphocytes are associated with the effectiveness of the chemotherapy. It seems when you look at the immunity of the elderly patient that probably the quality of the immunity is lowest than in the youngest one. So in general, I will say that for those patients who could have clear benefit from local treatment without neoadjuvant approaches, the elderly one, I will not strongly recommend to use systematically the neoadjuvant approach. Apart are the very aggressive tumors. For the youngest one, we have some signal from the NSABP-B18 showing that in the very young patient, maybe we'll have some impact of the neoadjuvant approach on the overall survival. This was one retrospective analysis in one trial with no demonstration in the other one, but it might be interesting.
Спасибо. Thank you.
Еще, пожалуйста, вопросы, если есть.